the volume of our work, and with the volume of our work, we have concluded the negative response to the treatment. So how to predict before the procedure itself, like this procedure is going to have a negative response. So I think that's the way forward, and we will have a lot of discussion on this, and we will first let Anirudh to present, and then we will have a I'll give my inputs, and then we will leave it to the forum to have more discussions.
Thank you, sir.
You can share your slide and you can go ahead.
Yes, sir. Is my screen visible, sir, here?
Yes, it is nicely visible.
Yeah, visible.
Okay. So, good evening, everyone, respected moderators and colleagues. Today, I'll be presenting a prospective observational study evaluating whether pre-procedural ultrasound assessment of synovial hypertrophy and effusion can predict treatment response following genicular nerve ablation in knee osteoarthritis. This work attempts to bridge the gap between the structural inflammation and interventional pain outcomes. This study was published in an open access index journal, that is the Journal on Musculoskeletal Ultrasound and Pain Medicine. This is the official publication of Daradia Pain Foundation, and it is under the editorial leadership of Dr. Samarjit Dey. It is indexed in major databases like EBSCO, ProQuest, CNKI, and others. So, knee osteoarthritis remains one of the leading causes of disability worldwide. While progressive cartilage degeneration and subchondral bone remodeling are well known, increasing attention has been directed towards synovial inflammation as a contributor to chronic pain. And this chronic pain, this affects the chronic pain, functional impairment, and also the quality of life. All these three are significantly affected. We follow a graded management approach for osteoarthritis of the knee. Usually, we start with the conservative measures first. And however, if the conservative measures don't work, a lot of times they go for surgical options. But is there a bridge that can be there? This is where we come, where we bridge the gap with interventional pain procedures as an minimally invasive alternative to surgical options. Genicular nerve ablation basically interrupts the nociceptive transmission from the superomedial, superolateral, and inferior-medial genicular nerves. Basically, the transmission is blocked over here, and patients get sustained pain relief for 6 to 12 months. Despite the established efficacy, the response rates vary considerably, as we will be seeing in the later slides. The traditional predictive factors, such as radiographic severity, age, and symptom duration, show limited correlation with outcomes. This variability raises the question, are we missing a biological factor? What does the literature say about knee RFA? RFA was established long ago for spinal pain back in 1970s. However, in 2011, like Sir mentioned, Choi et al., they published the first RCT, which validated the genicular nerve RFA. Subsequent years saw a lot of other techniques like cooled RFA. There were a lot of other studies, multi-center studies, and more recently, even predictor studies have come, where they're studying various factors which may be affecting the outcomes, like some clinical factors like use of opioids, presence of depression, how severe the osteoarthritis is, and how many number of nerves have been targeted. But still, there are no studies which have incorporated synovial ultrasound biomarkers. This is the first paper, by the way, the first RCT on RFA for knee, where Choi et al. Showed that approximately 59 to 65% patients achieved more than 50% pain relief for up to 12 weeks. This established a proof of concept. Now, before discussing the predictors, it is important to establish that genicular nerve ablation is overall effective. So this 2025 systematic review published in Pain Medicine included 28 studies involving over 2,200 participants. The pooled success rate for RFA in these patients was, that is basically at least 50% pain reduction, was 51% at 6 months and 43% at 12 months and 58% at 24 months. They also noted that large lesions produced higher success rates as opposed to smaller lesions. So overall, approximately half the patients receive meaningful pain relief. But what about the other half, right? Here we have again another systematic review which had 8 RCTs and 627 participants. Here they had basically studied conventional RF, cryo, bipolar against sham blocks. The main thing that was to be noted from this systematic review was that there were no serious adverse events associated with use of RFA for knee. However, again, even over here, the outcomes were quite heterogeneous. Success rates were still not that great. And here we have one more study that is by Chang et al., where they demonstrated that ultrasound-guided genicular nerve ablation improves pain, and more importantly, it preserved the quadriceps strength, proprioception, balance. So this really assured us, even if we are blocking some of the nerves around the knee, we are still maintaining the functional safety. But then again, what about the response variability? Am I audible?
Yes, you
You
are
are, you are
audible.
nicely audible. Go ahead,
You
please.
are audible.
Yes. So while more recent systematic reviews report just approximately 50% responder rates, it is important to see that there are a few other studies also quite recent which show that the response is not that great. Like this particular systematic review, where they had studied 25 trials. This was published in 2025, by the way, in osteoarthritis and cartilage. Here, what the authors noted is that RFA provided just modest short-term pain relief at 4 weeks and 12 weeks. However, the benefits were not present at 24 to 48 weeks. And these authors even, they have advised against the use of routine use of RFA for osteoarthritis knee, saying basically we have to be careful with the use of it until more evidence is available. This was a retrospective predictor study of 124 patients undergoing RFA. They studied a lot of factors. Basically, they saw if age was a contributor, sex, and a lot of other things. And in this study, only one factor came positive. That was the baseline pain. There was some trend while they were seeing with the uh, in this study, basically, if depression may be contributing a little bit and pre-procedural anxiety, but then again, statistically significant was only the baseline pain. It's very interesting to note that in these patients, 81% patients had a positive response to a diagnostic block. That is, with the diagnostic block, 81% patients had pain relief. But then again, post RFA, only 35% achieved the pain relief. So, what is the research gap? We have strong evidence saying that genicular nerve ablation works, but then again, it is only 50%, around 43 to 74. Genicular nerve ablation is superior to the intra-articular interventions, but long-term benefit is uncertain. We don't know what exactly is happening, what are the factors. So that is why we need a little more studies to study basically what might be the predictors, and we may have to establish some standardized protocols, starting with the ultrasound assessment of the synovial inflammation. So that's what was done in this paper. So musculoskeletal ultrasound allows real-time assessment of synovial hypertrophy and effusion. These represent the chronic and active inflammatory phenotypes. So two key parameters are noted, that is synovial hypertrophy, which is written as SH in this paper, and synovial effusion, that is SE. Synovial hypertrophy reflects the chronic proliferative changes within the synovial membrane. There will be increase in the synovial layers, and there will be vascular proliferation, and this usually reflects the long-standing inflammatory activity and synovial remodeling that has been happening in the knee. And synovial effusion, usually this correlates with the symptom flare-ups that happen in these patients, and this suggests active inflammation and capsular distension. This was a landmark study, a multi-center study, which was done in Europe. Basically, they studied over 600 patients across multiple countries, where what they did was they used B mode ultrasound of the suprapatellar recess to detect if there was synovitis. And what they noticed was that over 47% patients had ultrasound detected inflammation. Specifically, they noted that around 16% patients had synovitis, Effusion was present in 43%, and both were present in around 14%. So inflammatory changes are not rare. They are quite common in symptomatic osteoarthritis. This was another study. This is basically a meta-analysis of observational studies. So they had included 29 studies with over 3,700 patients with osteoarthritis of the knee, and they wanted to see if there was any ultrasound detected inflammation. So even they noticed that around 52% patients had effusion, synovial hypertrophy was present in 41%, and Doppler signal was detected in around 33%. And they also noted that effusion was more consistently associated with pain. What they noticed was that there was not much association with synovial hypertrophy, or it was weak. So synovial hypertrophy may reflect some chronic structural inflammatory burden rather than just direct nociceptive drive. So this distinction becomes important when considering procedures like genicular nerve ablation. So coming to the rational and study hypothesis of the paper that I am discussing. So inflammation and pain. So active synovial inflammation characterized by significant effusion can cause pain through chemical stimulation of the nociceptors. Nerve ablation may be less effective in patients with active inflammation, as the pain is primarily inflammatory rather than neurogenic. And understanding the relationship between inflammation and pain can improve patient selection for genicular nerve ablation and possibly enhance the treatment outcomes. These were the study objectives. The primary objective was to determine whether pre-procedural ultrasound assessment of the synovial hypertrophy and effusion can predict pain relief and functional improvement following ablation in osteoarthritis knee. Secondary objectives was to see if there is any relationship between the ultrasound parameters and treatment response, and evaluating potential clinical utility of incorporating ultrasound screening in the pre-procedural protocols. So whether we should include this in our routine pre-procedural assessment. This was a prospective observational cohort study, and this was a single center tertiary care center study conducted for over 3 months. Here, 24 patients were included with symptomatic osteoarthritis of the knee, and all procedures were performed by experienced practitioners who had training in musculoskeletal interventions. The study population was the consecutive patients with symptomatic osteoarthritis knee who were referred for genicular nerve ablation. They were screened for study eligibility, and informed consent was taken. This was the exclusion and inclusion criteria. So they had included patients from 40 to 80 years, osteoarthritis grade of greater than equal to 2, chronic knee pain for more than 3 months, pain score more than or equal to 4, failed conservative management, ability to provide informed consent, and to be able to follow up the patients. These patients are excluded when there was active inflammation or active infection or systemic infection, coagulopathy. So pre-procedural ultrasound assessment was done with the high frequency linear probe, and basically, so starting with the synovial hypertrophy assessment. This was done using the modified OMERACT grading system, adopted specifically for osteoarthritis. So synovial hypertrophy was described in 4 grades, starting with grade 0, that is normal, no detectable synovial thickening, and grade 3 was severe. So grade 1 had minimal synovial thickening. I'll be showing the pictures after this. So grade 1 is minimal synovial thickening without significant bulging of the femoral over the femoral bone. Synovial tissue is visible but not prominent, maintaining relatively smooth contours. Grade 2, that is moderate, where there is moderate synovial thickening, where there is noticeable bulges over the femoral bone surface. Irregularity of the synovial contours with increased echogenicity and thickening. Grade 3, that is severe synovial thickening with marked bulging and irregular lobulated contours, extensive synovial tissue perforation. This is a normal ultrasound image showing grade 0 synovial thickening basically. Here we can see the femoral condyle, and this is the tibia, this is the medial joint line, and we can see the medial meniscus is normally situated. On top of that, we can see the medial retinaculum and the MCL. Here we have the photos of grade 2 synovial hypertrophy. That's the first one. So here we can see that there is a moderate synovial thickening with noticeable bulging over the femoral bone. And in the grade 3, there is quite a bit of thickening, and we can even see the heterogeneous echogenicity within the synovium. over here. And we can also see that the meniscus is extruded, MCL is quite bulged over here. Next, coming to the synovial effusion assessment, this was done using the established ultrasound criteria. Again, 4 grades were there. That is, grade 0 is no effusion. Grade 1 is when the maximal dimension of the fluid was more than 2 mm. Grade 2 was 2 to 5 mm, and grade 3 was more than 5 mm. And this effusion assessment was done in the suprapatellar recess with the linear probe placed longitudinally along the quadriceps tendon. So in this picture, this is a normal suprapatellar anatomy. Here we can see that on the right side, that's the patella. Left side, lower down, that's the femur with the hyaline cartilage. We can also see the suprapatellar fat pad, prefemoral fat pad, and the synovial recess is barely visible because right now there is no effusion. Here we have grade 2 synovial effusion. That's the first picture. Here we can see that, nicely see that there is a fluid in the suprapatellar recess. Here the measurement is 4 mm, so that comes as per the criteria moderate. And in the third picture, we can see that there's quite a bit of fluid, right? So this comes up to severe. That is, or rather, grade 3. All the USG images that were noted were documented properly, and at least 2 people went through the images, and some images were even given to a independent person for independent review to make sure that there was no inter-observer or rather there was reliability in the inter-observer assessment. The genicular nerve ablation procedure as such, so the pre-procedural preparation was done properly, assessment was done, and the anatomical this procedure was done under ultrasound guidance. And for most patients, the 3 nerves, that is superior medial genicular nerve, superior lateral genicular nerve, and inferior medial genicular nerve, these 3 were targeted. The superior medial and inferior medial were given in all patients, and superior lateral was given in some patients, which I will be talking about in the statistics. The procedure was done in under aseptic precautions, and sensory and motor stimulation was done before starting the lesioning. The lesioning was basically done at 80 degrees Celsius for 90 seconds at each target site. And post-procedure, 0.5% bupivacaine was injected at the lesion site. Here are the images showing the procedure basically. So the first image, we can see that ablation of inferior medial genicular nerve is done. Second one shows the superolateral genicular nerve, and third one shows superomedial genicular nerve. Post-procedure care, all the patients were monitored in the recovery area for 30 minutes, and they were advised activity restriction for 24 hours, and they were asked to contact if there was any concern. So what were the outcome measures? So the first outcome measure, or rather the primary outcome measure, was pain intensity. This was assessed using the NRS, that is 0 to 10, and it was assessed at baseline and 4 weeks post-procedure. Treatment response was defined as if there was more than or equal to 50% reduction in the NRS score 4 weeks post-procedure. Secondary outcome was whether to evaluate whether the patient's functional status has improved. And this was done using the Western Ontario and McMaster University's Osteoarthritis Index, also called WOMAC. And there was a positive response if the WOMAC score improved by more than or equal to 20%. This is the WOMAC score. This is a validated patient-reported outcome measure assessing pain, stiffness, physical function in knee osteoarthritis. This provides a structured way to quantify symptomatic and functional improvement following interventions like genicular nerve ablation. This is a total of 24 components, 5 in pain, 2 for stiffness, and 17 for physical function. So statistics for this study. Sample size, it was convenient sampling and it was consecutive sampling. So total sample size came up to 24. No randomization was done as such. And whatever data was collected, it was and analyzed. It was the descriptive statistics was done with mean and standard deviation for continuous variables and categorical variables as frequencies and percentages. Inferential statistics, pain and functional outcomes were evaluated with PET test. Response rates were compared between ultrasound categories using Fisher's exact test. And predictive modeling was done using the logistic regression analysis. And even Firth's analysis was also done because the sample size was a little small. And p-value less than or equal to 0.05 was considered statistically significant. Coming to the results. So these are the baseline demographics and procedural parameters. Here we can see that all the procedures were done under ultrasound guidance. It's also interesting to note that steroid was used in all patients, that is immediately after the genicular nerve ablation, and the superomedial and inferior was done in all patients, whereas the superolateral was done in only 3 patients. 21 patients did not receive the superolateral genicular nerve block. Overall, both NRS and WOMAC scores showed significant improvement at 4 weeks after the nerve ablation, with more than 50% response rate. It was positive, that is, p-value was less than 0.001 for both NRS and WOMAC improvement. However, what we need to see is that patients who had minimal effusion, they had much better response. The patients who came under grade 0 of effusion, there was 100% response, whereas as and when the effusion was increasing, the response kept decreasing for both NRS as well as WOMAC. And here we can see that patients with mild or no synovial hypertrophy again had demonstrated significantly greater reductions in both WOMAC and NRS scores. Responder rates were markedly higher in mild or no hypertrophy, that is around 80% versus 30%. And on multivariate Firth model, it is seen that hypertrophy independently predicted response, while effusion was not that significant. Discussion. Significant pain and functional outcomes, functional improvement was demonstrated after ultrasound-guided genicular nerve ablation in osteoarthritis knee. Both WOMAC and NRS scores were significantly improved in all the patients at 4 weeks, and synovial hypertrophy and effusion can be used as prognostic markers for patient selection. Consistently good response in patients with the absent or mild effusion as compared to those with the prominent effusion, and improvement better in those patients with mild to no synovial hypertrophy. So synovial hypertrophy was seen as an independent predictor of treatment success, with odds ratio of 8.75 with 95% confidence interval, p-value of 0.007. So predictive role of synovial ultrasound findings. Effusion and hypertrophy imaging reflects acute inflammation, while hypertrophy indicates chronic synovial remodeling linked to chronic pain. Effusion may be seen as a predictor of magnitude of improvement, whereas hypertrophy basically will tell us what is the probability of a meaningful response. Chronic synovitis may produce persistent inflammatory mediators independent of mechanical nociception. So when there is inflammation, denervation alone may not be sufficient. Here we have a study where MRI quantified synovial effusion was noted in patients undergoing genicular nerve ablation. And this study showed that patients without severe synovial effusion had significantly better pain outcomes after genicular RFA. In contrast, the presence of marked effusion was associated with poor response, suggesting that higher inflammatory burden may reduce treatment effectiveness. Comparison with literature, there were no other studies as such where either effusion or synovial hypertrophy was studied to predict the genicular nerve ablation success. So from our study, what we have seen is that hypertrophy appears to be more predictive of GNA, but otherwise there were no other studies where this was studied. So what are the clinical implications? We might be benefiting quite a bit if we incorporate ultrasound phenotyping pre-procedurally. It's quite simple, inexpensive, and it is quite clinically valuable for predicting the genicular nerve ablation outcomes. Effusion quantification may help us to see what is the magnitude of symptom relief that we can expect. So like we had seen in the previous studies, and even in this study, when there was quite a bit of effusion, we may not get a good improvement. Similarly with hypertrophy, if the hypertrophy is quite bad, then they may not really respond to the treatment. What are the strengths and limitations of the study? This was the strengths are basically that this was a prospective design. Uniform ultrasound protocol was used. OMERACT-derived grading. Fourth, penalized regression was used because there was small sample size, and real-world sample reflective of clinical GNA practice. The limitations were that the sample size was small. There was a short follow-up period of 4 weeks, and absence of Doppler which may further refine inflammatory phenotyping. So conclusion of this paper was that genicular nerve ablation significantly improved short-term pain and function in knee osteoarthritis patients. Synovial effusion severity and hypertrophy severity influenced the genicular nerve ablation outcomes, with effusion correlating with the magnitude of improvement and hypertrophy predicting clinical success. And we can basically ideal candidates for genicular nerve ablation would be patients who have mild hypertrophy and minimal effusion, while those with advanced inflammation may require additional anti-inflammatory therapy before we consider them for ablation. Now, coming to the critical appraisal of this paper. So, about the need for the study and research question and objective. There is a clearly identified gap that there is no prior ultrasound-based synovial biomarker studies in genicular nerve ablation. So, clinically relevant question: can ultrasound phenotyping predict response? And this study was justified by the heterogeneity of the response that we see with the knee radiofrequency in patients with osteoarthritis of the knee. The study design was appropriate, and this was prospective. But one thing to note is that there was no control group. But then this is the first study, and the sample size was also very small. There was the inclusion and exclusion criteria were clear, and consecutive sampling reduces the selection bias. However, there was no randomization that was done, and all the data collection methods were appropriate. Data analysis was appropriate. The results were also reported in a clear manner, and discussion also, they acknowledged that these were the limitations, and yes, and usability of the findings in the clinical practice. Yes, so whatever they found in this study is quite practical, and it's an inexpensive tool. It is easily implementable in pain clinics and may improve counseling and patient selection. However, since this is the very first study that has been done where the synovial hypertrophy has been compared against the outcomes of genicular nerve ablation, we require further validation studies. So take-home message: genicular nerve ablation works, but not for everyone. Genicular nerve ablation provides short-term pain and functional outcomes in osteoarthritis knee. However, the treatment response remains at 40 to 70% as of now. And synovial phenotype matters. Whether there is synovial hypertrophy, the synovial hypertrophy predicts the probability of success, and effusion influences the magnitude of improvement. And pre-procedural ultrasound, simple, inexpensive, clinically feasible, and this may help us select our patients better, and we can even counsel them and maybe optimize the treatment, like starting them on anti-inflammatory before we take them off the procedures. Thank you.
So that's really a wonderful presentation, Dr. Anirudh, and I would like to congratulate Dr. Sravaya for Shravaya. Yeah. I think it's really a wonderful paper. So how I receive this paper, I just enumerate, because I think we have fairly a good bench strength today for this, because this is going to unfold a lot of things in knee arthritis management. So I think probably this is the first prospective study integrating the ultrasound inflammatory biomarkers with genicular nerve ablation outcome. This is like, I think this is something, I think this is a beginning. I think lots to follow this, but I think we take the credit and you take the credit of doing this first prospective study, and congratulate for that. And what is so important in this particular paper is like it is introducing the mechanism based patient selection. Like generally we know how the patient selection, we always use, the Kelly-Green Lawrence classification, but this is like basically a mechanism based patient selection, which is like more pathophysiological evaluation. So only when you analyze the pathophysiological cause or the analysis of the pathology, I think then we can titrate the treatment in a better way. So there is a mechanism involved here in this paper, and the patient selection is based on the mechanism. That is another important finding I see in this paper. And there is clear-cut shift from the radiographic grading to the inflammatory phenotyping. So that is what is more important. What Anirudh presented is like about the inflammatory phenotyping. which is very important in assessing the knee arthritis patient and in making their treatment plan. Let's make the inflammatory phenotyping and then see like whether what treatment we are going to offer, or is really the genicular nerve GNA is going to be effective for them. So he has narrated so well. In briefly, like for the benefit of others, I put it very in a nutshell. So overall, this particular paper said there is an effective pain relief, like which is the p-value is less than 0.001. So obviously, like there is a significant reduction in pain. But what about the predictive roles of the ultrasound markers? So we have deep dived too much. We are not just improvising the ultrasound markers for the predictive outcome, but also like what is their predictive roles as a markers. I think as rightly said, synovial effusion is something like we need to assess. Definitely we need to assess yeah, in ultrasound scanning before we plan the intervention. But as rightly said, effusion is mainly correlating with only the magnitude of improvement. As I think it was clearly stated, it is not an independent predictor, because if you see this particular paper, the odds ratio, the adjusted odds ratio is only 0.67 with regards to the effusion. So I think that is the important one. I think I just want to add this with Anirudh. I think most of it he covered, but I think this mention is also important. Like the adjusted odds ratio for the synovial effusion as the predictive role of ultrasound marker is just 0.67, which means like it correlates with the magnitude of the improvement post treatment, but is definitely not stand as an independent predictor of treatment success. I think one or two other studies, one in Taiwan, there is one, I mean, Chang published in 2021, and that was on hyaluronic acid injection, HA, not with GNA. I think for the GNA, I think this is the first paper. But with HA, it was a paper, there was a paper in 2021 by Taiwan pain physicians by Chang et al., like where he also rightly mentioned about the predictive role of synovial effusion in HA. Again, it is not an independent predictor of the treatment success after the adjustment. So it's mainly the odds ratio is 0.67. But synovial hypertrophy, if you come, it is actually quite important to discuss more on it, because it's a strong independent predictor of clinical response after your genicular nerve ablation, because the odds ratio is 8.75. That is quite a bit. The adjusted odd ratio of 8.75 is incredible, and with the p-value of 0.007. So that clearly states patient with even minimal hypertrophy has got 8.8 times higher odds of responding compared to those with moderate to severe hypertrophy. So this is one important point I would like to highlight here in this particular paper is this one. The advantage of synovial hypertrophy over effusion as a predictive ultrasound marker is the odds ratio is 8.75. So the minimal hypertrophy, synovial hypertrophy patient have got 8.8 times the higher odds of responding to your GNA when compared to moderate to severe hypertrophy. So that is the key point here. So obviously with grade 0 to 1 hypertrophy, we have got 80% responders with greater NRS, with I think more than 4 NRS reduction and 33 points WOMAC improvement. But contrarily, with grade 2 and 3, significant drop in the responders. Like from 80, it has dropped to 28.6, and literally like there is no improvement in WOMAC. I think this is the most important salient key inference what I observe in this particular study is the hypertrophy, synovial hypertrophy is a strong independent predictor of the clinical response after the GNA. So again, as I mentioned before, the pathophysiological, how are you going to interpret pathophysiologically? Because it's mechanism based. So we all know effusion indicates an active inflammation and it is reversible. So what are all the inference you are going to derive by doing your pre-procedural ultrasound and by identifying the magnitude or the quantum of effusion? The magnitude of the effusion and the quantum of effusion indicates that active inflammation, which can be potentially reversible by you start an anti-inflammatory therapy. And if patient doesn't respond to any anti-inflammatory therapy, bring down the inflammation to some extent before we plan for the GNA. I think that's the point here. That's the point here. So it's a roadmap. It's really a roadmap. The effusion as a ultrasound biomarker is a roadmap which is going to tell a cytokine-driven active reversible inflammation. Try with anti-inflammatory therapy first before we consider a GNA. So that's the key point here. if you have a pathophysiological interpretation to the effusion. Coming to the hypertrophy, how are we going to interpret? Because it is basically a chronic structural synovial remodeling because of the persistent inflammatory mediator production. It is effusion is more active and acute. Hypertrophy is more chronic, and we have got the repeated inflammatory burden, repeated inflammatory mediators burden causing a chronic peripheral and central sensitization. Again, they are all the poor responders to the denervation. So that is why the hypertrophy has got the better predictive value when compared to the effusion, because like it is very less responding to the denervation because of the chronic noxicitive sensitization, and that indicates the chronicity of the problem. So therefore, if the pain is mainly neurogenic, if the GNA really works, if the pain is more inflammatory, whether acute or chronic, consider the GNA response, or we have to accept the GNA response is limited if the pathology is predominantly inflammatory. I think we have to accept. So try an anti-inflammatory method before we consider the GNA response is the message what we are going to derive from this paper. So the ideal candidates for GNA, to put it in nutshell, is a mild or no synovial hypertrophy, or a very minimal effusion or less than 2 millimeter, or pain should be a chronic neurogenic pain phenotype. If you want to really go into GNA directly, I think these are all the real indicators. Your pre-ultrasound, pre-procedural ultrasound showing mild or no synovial hypertrophy, a minimal effusion with neurogenic pain predominant. And the poor candidates are obviously the other way around, the moderate to severe synovial hypertrophy patient with a high inflammatory burden in the joint. So as I mentioned, with a high inflammatory load, the best would be to try with a pre-procedural steroid injection or the PRP or the hyaluronic acid. HE also has got an evidence saying to be effective in inflammatory pathologies. Obviously, we all know about the role of PRPs, and of course steroid if there is no contraindication for steroid. And even sometimes your anti-inflammatory medications should be considered before we try a GNA in acute inflammatory burden conditions. So the overall conclusion and the take-home message on this particular fantastic, incredible paper written by Sravanya is like the ultrasound phenotyping improves the patient selection for sure for genicular nerve ablation, and synovial hypertrophy is a strong predictor compared to the effusion. I think should be considered before we choose to go ahead with the GNA. And the combined assessment, of course, is really required. Combined assessment of both effusion and hypertrophy is going to increase the prognostic accuracy, and incorporating ultrasound screening into your routine evaluation is going to really enhance the clinical success rate, as we only want happy patients and we are not going to do any placebo procedures way forward when so much of evidences are coming in a very objective way. And GNA should not be offered blindly based on just the radiographic and the pain severity, which is currently has been followed so far. Like we only follow the KL grading and the pain severity, and then we go ahead and do the GNA. But I think it should be offered based on the ultrasound phenotyping, which is going to be the future and improves the patient selection for an effective genicular nerve ablation. So that's my submission for this particular journal club, and it's a well done presentation by Anirudh and a very good job by Sravanya. So I open this forum for discussion for others, like if they have any questions.
Yes, there are lots of questions. I might be asking the questions, what is there in the chat box. But before that, I'll be asking others to ask the question directly, and regarding the paper, regarding the idea, how it came to Dr. Sabya, and also the Dr. Anand, Dr. Anirudh, and myself is there to answer your questions. So any question you can ask directly, you can unmute yourself and you can ask the questions. And also we'll be taking care of the questions that is there in the chat box. Okay, if no direct question is there, let me read some of the questions which is there in the chat box. Can RF, this is question asked by Dr. Brishali, can RF work in the grade 4 osteoarthritis knee patient with varus deformity? Anyone can answer this question?
Yes, sir, it is going to help in grade 4 also, who are not a surgical candidate for
Yes, grade 4. In fact, in this study also, Sabha has done that the more than grade 2, that means grade 3 and grade 4. And there are lots of paper which is telling even the grade 4 it is working. But again, many cases it is not working. So here, which is working or which is not working, that is not based on the KL radiological marker, that radiological grading. That is what has been emphasized by Dr. Anand, Dr. Sabia, that if we are selecting our patients based on the KL grading, X-ray grading, then the chances of the failure is going to high. And here we are having some additional predictive, instruments to understand what might be the other things. Okay, so other thing is, in fact, grade 4 your deformity, the first choice should be the surgery. But if there is some contraindications, RF can be tried, provided this kind of things are not there. Synovial hypertrophy is not there. So then another question is, why is superolateral genicular nerve was not targeted in all the patients? Can Sabha answer this question?
Sir, good evening, sir.
Yes.
Because maximum of the patients are the mechanism is medial joint is the weight bearing area, whereas not the lateral. So mostly the nerves which will be involved will be the superomedial and infiromedial genicular nerves. But very few cases there will also be involvement of the lateral joint line also. So in those cases we can try superolateral genicular nerve.
That means if there is no lateral knee pain, you have not included the superolateral. Am I right?
Yes, yes, sir.
So in those cases, you have included the superolateral only where the pain is also there on the lateral side. Right. Yes. I hope this answered this question nicely. How to manage pain during the genicular nerve ablation? Most of the patients have very severe pain before and after the procedure. Yes, this is one of the very important part. Particularly, the genicular nerve is very close to the periosteum, and most of the times you are touching the periosteum, and that is causing pain. So, Sabya, what was your inputs, and other can also participate in this question, that how to take care of the pain during the procedure?
Before the procedure, we are actually giving the local anesthesia, sir. And even after the procedure, we are giving steroid to avoid the denervation.
Deafferentation pain.
Deafferentation pain, yes, sir.
So procedure-related pain is given with the liberal local anesthetic. In fact, in our center also, we do not do the sensory and motor testing. The problem with the liberal local anesthetic is that sensory and motor testing cannot be done if you are giving liberal local anesthetic. So what we do, we are basically during the procedure, we rely more on the genicular artery rather than the sensory and motor stimulations, because sensory motor stimulation, and in this paper also very clearly Anirudh mentioned that even this how much is the predictive value of the positive diagnostic block. And here in one of the paper, the Anirudh has clearly shown that it was almost 83% or something, but finally when the procedure was done, the outcome was only something around 34 or 35%. That means the predictive value of the diagnostic block is limited. And what is my also observation is that the predictive value of a good outcome depends on the selection on the genicular artery. And in fact, earlier when we started this procedure, we used to do only under the CRM guidance. And recently we do not use the CRM at all because of the anatomical variation of the genicular artery and genicular nerve so much. So that means the location of the genicular nerve, sometimes many times you can see the genicular nerve as well on the ultrasound. So if you can do that, that is the best one. But otherwise, ultrasound is a very good one. And so what we do after locating the genicular artery, we give the liberal local anesthetic so that the procedural pain is not there. But again, some people even give the the spinal anesthesia also. I've seen.
Yeah, I'm coming there, sir. I would like to add few points here.
Yes.
So I generally give subarachnoid block for these patients, and then I proceed, because like if I have to stimulate, I can stimulate anyway. But I think with ultrasound intervention, so the point of stimulation is not really needed, as we are going with a genicular artery landmark. So what I generally do is, like, for the benefit of many students here. So first I do a longitudinal scanning. and then get the genicular artery in a short axis view. And once I get the genicular artery at the condyle shaft junction, I try to keep the short axis view of the genicular artery in the midpoint of that ultrasound probe, and I mark it with a marker pen, and then I'll make the realignment to axial scanning. Once I make the longitudinal into an axial scanning, the artery becomes long axis. So that long axis view of the genicular artery should be seen before I put the needle as an in-plane from anterior to the posterior, and then keep the needle tip just above the pulsating genicular artery in the long axis view. So there is no need actually for stimulating that nerve. And how to prevent the post-procedural pain is like you give a subarachnoid. I'm not motivating, I'm not telling like every others to do it in the subarachnoid block. If you have a facility to do that, I think that is one such things, because like the subarachnoid block takes the pain completely away, and then especially when you're doing newer targets and bilateral knee, especially like 12 lesions, it's really going to be very painful. And sometimes we overexceed the local anesthetic dosage, causing local anesthetic toxicity. So either we can do a subarachnoid block and then proceed with an ultrasound guided intervention based on genicular artery landmark. So this is one point I would like to add here.
Okay, thank you, Anand. So the very important part is, yes, genicular nerve ablation, RFA is a painful procedure, and either you can, the subarachnoid block, like Dr. Anand told, many people are doing like that, or you can give the liberal local anesthetic. Problem with that, you cannot elicit the nice stimulation. Nerve ablation fails. Again, Botox is not new. In fact, it is there more than 20-25 years back. I can remember I did the Botox intraarticular injections in 2004-2005. The result is not that great. Some papers are definitely there, but it should not be coming as a routine procedures if the genicular ablation fails. Rather than other regenerative therapy can be considered, like the WOMAC or the other regenerative therapies in the grade 4 osteoarthritis can be a better choice. It is my opinion. Any other opinion from Anand or anybody else, that if the genicular nerve ablation fails, then what other things we can consider?
So one is like as you rightly mentioned, we can go for a growth factor concentrate if there is inflammation is very severe. The growth factor concentrate, I feel like, has got better result when compared to the PRP. So of late I see better results with GFC in joint. Obviously, like if joint denervation doesn't work, then obviously like we are going to completely rely on what are you going to do with the inflammation. So if there is no role for steroid, then I think we need to go for the growth factor concentrate, and then see like how is it going to help. But I think now with more RCTs coming, because the initial OA-RSA guidelines was not very conclusive and supportive of the stem cell therapy for any joint. But same the OA-RSA, when compared to 2023 guidelines, they have come with the 2025 guidelines saying PRP is effective. Previously, it was not effective according to them. So in 2 years with more RCT coming, and they say the 12 months result after the platelet-rich plasma into the knee has got a better evidence. So I think like in that case, we need to try with growth factor concentrate. The advantage is like there is no RBC, there is no WBC. So when there is already more inflammation there, more pain there, we don't want any WBC there and any RBC there. So
it means you are not recommending Botox. You are just going to go back to the regeneration therapy.
Yeah.
Am I right?
Regeneration more into growth factor.
Okay.
More into growth factor, not into a cartilage regeneration part, because obviously in grade 4 arthritis, we are debating like the regenerative therapies, the stem therapy has got the limited role, but there is definitely a role for growth factor concentrate even in advanced osteoarthritis.
Yes, my result, my observation is also same. that most of the times we used to tell that, okay, grade 4 osteoarthritis regeneration therapy do not work, but my experience is different. Even in the advanced osteoarthritis, grade 4 osteoarthritis, it works. Next, let me come to the next question, that can you use alcohol, or here it is mentioned as phenol, or maybe the alcohol as well, be used in the genicular nerve ablation if RFA is not available? So some papers are there, some people are also doing, but again the problem is that if we are going it, the most important aspect is it might be trickling down, and you might be ablating the other important nerves, particularly the tibial nerve and the peroneal nerve. So these are the concern. But small amount, some people are using, and they told that okay, results are good. Anybody who is having the experience of having the phenol or alcohol injections in the genicular nerve, can you share your experiences? Generally, it is not recommended. The apprehension is it might be tickling down, and it might be causing the main nerve, tibial nerve, and the peroneal nerve might be involved. So that is the reason why it's not recommended. But some people are doing it. I know that. So anybody having the experience, can you share your experience?
Sir, I am using alcohol.
Okay, you can share your experience, please.
Actually, I am not using RFA at present for genicular nerve neurolysis.
Okay.
My cases are actually the pain control is better with even severe valgus deformity or varus deformity patients also.
So have you came across with any complications in your patients with using the alcohol?
No, with ultrasound guidance, there is no neurological problems yet.
And how much volume you are injecting in the volume of alcohol you are using?
1 ml local anesthetic with 1.5 ml absolute alcohol.
Okay.
I have one question for Dr. Murali Krishnan, and so rather two questions. Like, what is your? Did you compare your alcohol with phenol anytime? Like, did you use phenol and compare with alcohol? That phenol is better than alcohol is one question. Second question is like, especially in inframedial genicular ablation, like the skin now distance is very, very, very small. Like, so have you come across any complication after post alcohol injection? The skin necrosis and skin defect has come, skin burns has come post alcohol injection.
Sir, for the first question, I am not using phenol at present. I was using it. Nowadays, I am not using it after a few mishaps with my own face and all those things by slipping off the syringe from the needle and splashing on my face. Then
so how you manage inframedial genicular nerve with alcohol, like where you have got the nerve just underneath the skin, the now because it's in the
secondly, to the second question, I haven't come across any skin injury because I am just flushing with a little local anesthetic after that, and after before removing the needle, I'm restyling it and compressing the area. So there was no problem still now. I have done quite a good number of cases with alcohol.
You use ultrasound or fluoroscopy for your genicular nerve ablation?
Mainly, it is a hybrid guidance. I use ultrasound for needle placement, and after that, I confirm it with the C-arm in AP and lateral views.
So when you use ultrasound, in case if you see the distance between the skin and the nerve is very small, like for example less than 1 centimeter, but still you would like to give alcohol. That's my question here, because like it's a skin it's a potential irritant, and in case so if the distance between the skin and the nerve is like for example 0.25 centimeters or 2.5, somewhere between 2 to 5 millimeter is the gap between the skin and the nerve. So like how safe it would be like when you use alcohol there without causing any skin damage? Because I'm just worried about that, because we know whether it is an RFA or whether alcohol, it's only the modality is different. Ultimately the ablation is the same. In fact, the chemical neurolysis, the spread is better, so it captures the nerve better than the
Yes,
chemical.
anatomical variation can be caught nicely, so success rate might be better. But again, what is my apprehension is the studies and the recommendations are still not there. So in fact, I'll be encouraging Dr. Murli to publish it, and more publications coming. If it is coming as a evidence-based recommendations, definitely if some juniors or fellows are asking, I don't have an RFA machine, shall I go for the alcohol? My recommendation will be straight away no. Because the senior people like Dr. Murli and others who are having the experience can be doing for a purpose of the study. They should establish it first. We should establish it first. I'm not discouraging anybody, but I should not be telling it's as a routine procedure because the concern again, because it's a fluid, it might be trickling down to the areas which is not desired. So that might be the one of the, like Anand told, it can be the skin lesion, sloughing, or it might be going more. The dangerous thing is it is trickling down towards the posterior side, and catching any of the nerves. So, but again, small volume might be helpful. But ultimately, the thing is, in this era of evidence-based medicines, unless you are having the sufficient number of studies, particularly those who are juniors, I'll not be recommending these procedures to be there as a routine procedure. I hope everybody agrees with this, that it should not be a routine procedure. More studies are needed, and more experience sharing is needed, that it is quite safe. Okay, let me come to another question. And this is a grade 4 OA with severe knee effusion around 40 ml, and without synovial hypertrophy, not responding to the intra-articular steroid, Botox, oral sulfa with the knee effusion effusion is recurring. Yes, this kind of patient is quite common, that you are aspirating it, giving steroid, and again within few days or few weeks, again the effusion is coming up. So these are the patients where I normally in my practice, I try to avoid doing any intra-articular procedures, not even the RFA, because of this huge effusion. I try to, even if I'm aspirating, not more than one time, because if there is a recurrence, I do not. What I do in these patients, I intensify the disease-modifying treatment like sulfasalazine, or if the patient is having the other features like the sacroiliitis, many patients might be having the sacroiliitis as well. We can add the tofacitinib for this inflammation to come down, and then only we will be planning for the procedure. This is what I do, and I'll be asking a lot of experienced, including Anand and the others, seniors. This kind of patients are not uncommon, that the patient is coming up with the effusion, if you're aspirating it, and again it is the recurrence of the effusion very quickly within a short period of time, and it's really a problematic cases. So what you do in your practice?
Certainly, they are not the candidate for GNA, sir, as we discussed for the last 1 hour.
Yes. But how are you going to manage this patient? You are avoiding the genicular ablation, that's right. But how are you going to manage this kind of patient?
One is like I generally go for an anti-metabolite, sir, and try and then see with a combination of steroid and an anti-metabolite. I had tried on few patients that has helped, like the combination of methotrexate along with the oral steroid course sometimes has helped me in alleviating the pain, and plus or minus the sulfasalazines also has helped. So as you said, like rightly said, the disease modifying drugs has got a role to play in this particular scenarios, because basically, like we have to decrease the inflammation. The synovial fluid indicates an acute active inflammation, so how to alleviate is the question here. So steroid with an anti-metabolite would be the right combo. So I have few patients whom I tried once a week methotrexate 6 milligram and stepped up to 12 milligram with daily 5 to 10 milligrams of prednisolone has helped really.
Okay, so mostly I feel everybody will be agreeing that we have to intensify the anti-inflammatory treatment by different ways. The definitely disease modifying drug will be the key one, but along with that, the other things like oral steroid also can be added. Anybody else wish to add anything with this kind of patient? Because this kind of patients is not uncommon patients. Okay, one question: how to manage patient with the knee pain along with the recurrent effusion grade 3? Okay, already we have discussed this question is similar. Then pain recurring after the RFA after 1 to 1.5 years. Okay. This is again an important question. That suppose you have done a radiofrequency ablation, we got a very good result, and pain is recurring after a year or after 1.5 years. So what are you going to do? And another important part, this has been asked by many people, particularly the orthopedic surgeons, that are we landing up with any sarcod joint? Are we going to go for the more deformity because we are ablating the nerve, so less pain, so more movement for the patients, and is the deformity is going to increase? So these are the two important questions that we can discuss it. That what are we going to do? In my practice, in a grade 4 osteoarthritis where the deformity is there, my first choice is always your surgical, because deformity cannot be corrected with any interventions. Gross deformity, whatever is the grade, normally I take for the patient for the interventions when the range of movement is fine, and the means full flexion and extension or near close to full flexion and extension, and also the varus and valgus deformity is very minimal. Absolutely not there. They are not the cases. Very minimal. Gross deformity and gross restriction of the flexion and the extension, we normally encourage this patient for the surgery. KL grade, we do not normally incorporate much, because there is a lot of discrepancies with the KL grading and the patient suffering. And the recurrence, if it is there, mostly we repeat the procedure, provided these patients are not a patient for the regeneration therapy. Regeneration therapy is, in our center, you always give the priority, because ablation, even if we are doing, we do it in combination, not over the regeneration therapy, because ultimately if you can regenerate, that will be giving a long-term and better outcome, rather, particularly the functional outcome, rather than only genicular nerve ablation alone. So in fact, we combine this regeneration therapy with the genicular nerve ablation for the better pain relief and the longer pain relief. And in that situation, the recurrence within 1 year or within 1.5 years is less common. This is our experience from our center. I'll be asking others to share their experience.
Yeah, so I have the same experience like you, sir. I have I have some patients whom I have done 3 times, 4 times genicular nerve ablations, especially even the cooled ones, the cooled radiofrequency. But the observation is quite funny. Like the time between the first and second is actually shorter than the subsequent ablations. Actually, studies are saying subsequent ablations have got diminished efficacy, and the duration of the pain relief is less. But I'm actually going to publish one paper like where the subsequent ablations, the pain-free period is more. Between 1 and 2, when compared to 2 and 3, it's more. So like
have you added any other regeneration therapy, or it is only
I added BMAC. I have bone marrow.
So that might be the reason of the
that's what I'm coming to. That adds to the point what you are saying. Like every time I do this, I will do with bone marrow concentrate. So there is some regeneration happening. So probably that is the reason the symptom-free period is more. So if the pain comes back, we need to repeat it. That's the point.
Right. Anybody wish to add anything with this point? That once the recurrence is there, how to do? So basically, you need to repeat it, because there is no limitations that how many times you can repeat it. Was the study population evaluated in the inflammatory markers? Was the CRP prior to the interventions? This question is for Sravya. That what about the inflammatory markers in this patient? Like
usually yes, sir. Usually they are not too much elevated, sir, like in rheumatoid arthritis and all.
So pure osteoarthritis, normally the CRP and the ESR level remains normal, right?
Yes,
so
sir.
in your patients, I hope most of these patients, you have not mentioned this in the study, that the ESR, CRP, this was not as an inclusion or exclusion criteria in your studies, right? Okay.
Yes,
okay. Inferior medial genicular with alcohol had a very bad, yes, that already we have discussed, because it is very close to skin. Any other questions? Pulse radiofrequency, role of pulse radiofrequency. In fact, I can remember, 20, 25 years back, That time pulse rate frequency was booming up. Everybody was doing pulse rate frequency everywhere. If you're searching in the literature, what are not the indication for the pulse rate frequency? They are putting the pulse rate frequency everywhere, thinking that it might be benefited. And intra-articular pulse rate frequency, some papers was coming, and intra-articular pulse rate frequency with 18 minutes, 18 to 20 minutes. This was the just putting the needle inside the joint and doing the pulse rate frequency. This was a few papers were there. I tried some of the papers, some of these things, but single modality as a pulse rate frequency intra-articular results was not encouraging. In fact, the very high failure rate, almost all. And even the pulse rate frequency for the genicular nerve also, I tried few cases. The results was not good. And in fact, the results, if we are going to the published literature also, the pulse rate frequency have a poorer outcome compared to that of the thermal ablation. So, Anand and the others' experience about the pulse rate frequency.
So my experience with, I think the Sluger has done a lot of work in pulse radio frequency, especially after 2000. But it's like more of, there is a forum, active neuromodulation forum right now, debating on the efficacy of pulse to over your conventional methods. But still, I have got limited efficacy of pulse.
Yes, I met this Menos Reuter in one of the conference that time, early 2000, and I was very much encouraged with his, the paper lecture. He was basically, demonstrating, and he was telling what are the mechanism for this pulse RF, what are the, the chemicals levels, what has been increasing, and the anti-inflammatory action of all those things. So I was very much encouraged with this paper, and I tried to do the intra-articular. I tried, those the genicular. That time genicular nerve was not that. Mostly it is the intra-articular. Before 2011, it was the intra-articular pulse rate frequency which was basically he was mentioning. And but again, my experience is extremely bad. So after doing few cases, I have stopped it.
I do pulsed rotate. I mean, I one of my lesion is your infrapatellar branch of saphenous nerve. So that I do a pulse radio frequency for the same reason. It is very superficial. It's just above the skin. Very superficial. Right. Just underneath the skin. So I think that's the only indication I do a pulsed RF.
Okay, so the best
treatment for the post-knee arthroplasty pain, and where the pain is predominantly neuropathic. I think the role of pulsed RFA comes for sometimes like it is post-knee arthroplasty pain with more of a neuropathic character. So just doing an infrapatellar pulse radio frequency ablation sometimes giving a very good relief, because we know the challenges of doing a genicular RFA post-arthroplasty. But the pulsed RFA of infrapatellar branch of saphenous nerve has helped many times in alleviating the neuropathic pain post-knee arthroplasty.
Okay. Treatment with a grade 3 osteoarthritis knee with the rheumatoid arthritis with elevated ESR and CRP. Again, what we do and what should be I'm sure everybody will be agreeing with that we must be controlling the disease activity with mild or no elevation of the close to normal. Now, exact normal is difficult to get, ESR and CRP level, and disease activity is less. Then we can go ahead with any of the treatment, like your disease, the regeneration therapy or genicular ablation, whatever it is. But again, the primary goal of this rheumatoid arthritis patient with osteoarthritis is definitely the inflammation to be reduced. Sir, what is the volume of the growth factor and how many settings the advanced osteoarthritis knee? Again, this question is from Dr. Anand. So what is the volume of your growth factor, what you are using?
Volume of the growth factor is 6 ml, sir, but the volume, the total volume taken is like close to 60 ml. 60 ml, like the 60 ml volume, which is like 2 times spins. First spin is 3,500, second spin is 1,500. That gives 4 to 5 ml volume. So, but I think the volume of blood what you take is the most important determinant factor in GFC. So minimum 60 ml volume. Sometimes I have taken 90 ml. Sometimes I have taken 90 ml and then augment the spin, 2 spins, 8 minutes, first spin 3,500, 3 minutes, second spin 1,500, and then get a volume of 4 to 6 ml, which is a very good GFC.
Okay, so I'm just quickly going through. Definitely some has asked about the rehab. Rehab role is definitely important. So exercise is a part and parcel of the osteoarthritis knee management. We cannot ignore it always. Always you have to remember this. Another question, maybe the last question: what is the role of the ozone injection? In fact, let me share my experience. In early 2000, between the 2000 to 2010, I used to use the ozone injection, intraarticular ozone injection, quite a lot of patients. Results was good. I do not be saying result is bad. Our protocol was to use a weekly once injection, and we used to repeat it 4 to 5 times. The results was good, encouraging, but not like PRP. So after the PRP, I gradually stopped using the intraarticular ozone because definitely the PRP and this regeneration therapy has much better result than the ozone injection. This is my experience. Anybody used ozone can share their experience. Okay, this much. Any other questions? Anybody you can ask, anybody directly, you can unmute yourself and you can ask. Dr. Anand, which GFC kit you are using? So there are several kits in the market. So
Arthrex, sir.
Okay.
I use Arthrex ACP.
Okay.
And take 90 ml. I feel the results are better with the 90 ml, and I use Arthrex ACP is working good for me.
Okay, Mamta has one question. Any use of the measurement of the synovial hypertrophy and the effusion pre and post the genicular RFA? Pre and post genicular
Like we
RFA.
have used the WOMAC and
Can you
other
explain your
scores.
question, Mamta?
Sir, like we have used the WOMAC score and the NRS score. So can we do like measurement of these things?
I don't think it will be, because ultimately RFA is not going to affect the inflammation. RFA has no role on reducing the inflammation. So the synovial hypertrophy or the effusion, it is showing you the acute or chronic inflammation. Effusion is acute inflammation, acute flare-up, and the synovial hypertrophy is a chronic inflammation. So RFA don't have any role on this inflammation. So I don't think any change will be there with even if we are measuring the degrees of this in the papers. I hope Sabha have you noticed any changes?
No, sir.
Okay.
Thank you, sir.
Okay. Any other question? Anybody can ask directly?
Sir, good evening, sir.
Yes.
Sir, regarding the patient's response, sir, after the RFA, the patient is getting a very good symptomatic relief. Once the pain is reduced, patient started doing all domestic activity and coming with the recurrence. So how long we have to restrict the certain activities like physical activity or domestic activity? How long we can restrict the patients?
No, restriction is not needed. Any of the interventions, normal household work should be encouraged. It is not that we will be allowing them or advising them rest for the longer period. Normally, within 24 hours, like here, Sabha has mentioned his paper. After that, we are after 24 hours. In fact, after the procedures, we can allow them to patient to go to the normal household activities.
Okay.
So this is not just for the genicular. Even with the other regeneration therapies also, we are not giving a prolonged bed rest. Only thing is we are restricting the heavy work. We are restricting the exercise program till the injection related procedures pain is reduced. We do not encourage them to do for the active exercises. Normally it takes something around 3 to 7 days. I know in my patient, I tell that you do all the activities after the procedures, routine activities, not the heavy work or not the prolonged walking or standing. These kind of things are not recommended, but normal, going to the toilets, going to the dining hall to have the dinners, these all the daily life activities to be encouraged. And the patient should be doing the exercise once the injection related pain is reduced. Maybe it might be taking them 3 to 7 days.
Okay, sir. Sometimes, sir, a patient is also having myofascial pain along with the OA, sir. So, how to handle this myofascial pain, sir?
Myofascial pain treatment protocols is similar. Most of this myofascial pain, what is my observation, is secondary to the pain. So muscle spasm is secondary to the pain. If you are taking care of the primary conditions, automatically the secondary conditions will be reduced, will be taken care.
Okay. Thank you.
Someone asked me a question. Do I use exclusively ultrasound for knee genicular? Yes, I only use ultrasound these days. Initially, when I started my genicular, now I used to do hybrid technique, but now I completely moved into ultrasound. Not just the reason for the hazards of the radiation, but I feel like it is like
No, success is so much. It is same for
success.
me. Initially I started with only with the CM, like the Choi original paper. So only with the CM, then hybrid, and then last 1 or 2 years, I am using completely only ultrasound. So it has increased our success rate, to a great extent. So
because of the real time, because as I went during the lesioning time, I always tell my PGs also, my fellows, when you are doing the lesioning, never take people, once you get the target, put the needle, then don't relax till the lesion is complete. You have to still keep the ultrasound probe on,
yes.
and you should
No,
see the
not only
lesion.
the probe on, another very important part is we have to stabilize the needle. I always tell our fellows that, okay, please hold it, stabilize the needle very nicely, because, otherwise the needle might be moving and your needle might be moving from your these things. But another good study we have started recently with our fellows are collecting the data, because these are very common questions in many of the forum. I have heard it, that what happens to the genicular artery, because we are very close to the genicular artery, we are targeting basically the genicular artery. Many times we do not see the nerve, so what happens to the genicular artery? And some paper says that there might be a possibility of the aneurysm is there. But what study we are doing it is very simple, that we are looking the genicular artery before and after the procedures, and we are seeing whether what happens to the genicular artery. Is there any ablation? Is the pulsation is still seen? Is the caliber is having any changes? And we are following up with the subsequently whether any changes are there in the genicular artery. And the thing is, what the initial studies is going on, what is our observation, that most of the times it is there intact, same way pulsating. There is basically no changes in the genicular artery pulsations and the caliber of the genicular artery as well. So this is one what we are doing. So we are constantly keeping the probe, and we are looking at the genicular artery pulsation, whether it is getting cauterized or it is ablated. So answer is no, nothing happens to the genicular artery pulsations. Okay, any other questions? No more questions. If anybody have any questions before you are ending, I'll be asking Dr. Anand to summarize the whole thing. And if still anybody have any question, I forgot to mention all the faculties like Shruti, like other Shushpa and the others who are there, the faculty here in this forum. You can make your comment, Shruti. You can unmute yourself and you can comment. Shushpa, you can comment before we are ending up. No comments? Okay. Any other questions directly? Otherwise, I'll be asking.
I want to thank Dr. Anand sir for joining us. We really enjoy every time you join and every time you give your inputs. And I'm sure all our fellows, we all enjoyed it. Thank you, sir.
Apart from our fellows, a lot of other doctors and old fellows are there. It was a big crowd. Once it was reaching around 135 or 36. So I hope everybody has enjoyed. And thank you. First, I'll be congratulating the Sabya for this nice paper, and Anirudh for a very nice presentation, and Dr. Anand for very nice inputs. He has shared his experience. As I told in the beginning, is a stalwart, has a lot of experience in doing this kind of handling this kind of patient, and has given his inputs all throughout. And I'll be asking Shruti also. Shruti, wish to share something?
Yes, sir. I want to thank each and everyone who has joined today's session, and it was truly insightful and very interactive session. And I am seeing in the chat box there are a lot of replies, and everybody very enthusiastic. They're very enthusiastic and participating and answering the questions. So thank you all of you, and thank you so much, Anand sir. It was very informative, and thank you for joining us, sir. And thank you, Anirudh, and thank you, Dr. Shravya, for a very nice presentation.
Okay, so before I'll be asking Dr. Anand to summarize and conclude, let me once again thank Dr. Sabya. And I'll be telling everybody, this was basically an original paper and the first of its kind. And I'll be asking everybody. Many times we discussed amongst ourselves, but those discussions, those thoughts can be converted into a study. And unfortunate part is we are lacking here, but we should not be. Everybody should come forward and should publish it. And the Musculoskeletal Journal of Musculoskeletal Ultrasound and the Pain, here we are encouraging everybody to submit it, and we will be guiding you. Even if you are submitting it, if it is not up to the standard, we'll be guiding you how to polish it and how to make it more palatable, more standardized. And I'll be asking all of you, like somebody was talking about their alcohol injections. Alcohol injections don't have that much of good publications. I'll be asking to make some original studies on it, compare with the RF, proof that it is having the better efficacy and the risk what we are actually thinking as a risk, prove it that it's very safe. Then people will be accepting it. So whatever you are doing, whatever you are practicing, whatever you are discussing, we can easily convert it to some kind of research. And we should be coming up with more and more research, so that all over the world people are telling, yes, in India there are not just number of pain physicians is thousands, but also the number of publications are also in thousands, not in hundreds. So now over to Dr. Anand to say the conclusion.
Thank you, sir. So like when I learned my pain medicine in America, like what I was told is like, first, instead of you giving good result or good pain relief to the patient, do no harm. So that was the first point, which was actually buried into my thoughts by my teacher. So similar way, when you are doing any intervention in pain, two things should go in your mind very clearly. Is that going to harm the patient or not? Okay, it's not going to harm. Second question should arise, is it going to help? These two are the things we should always ask yourself before we offer an intervention to the patient. So that has got relevance because such an incredible work Shravya has done. I should really once again congratulate her for this first prospective study which she has conducted using an ultrasound inflammatory biomarker is going to be the future. Why I am telling, like, we are improvising the pathophysiological considerations here, and we are choosing the intervention based on the mechanism. The patient selection of the procedure is based on the mechanism here, and that is only is going to give a paradigm shift here from how we are going to move away from just mere the radiographic grading to our inflammatory phenotyping. So the inflammatory phenotyping, we are going to improvise the ultrasound and improve the patient selection for the genicular nerve ablation is the key point in this particular talk today. I want all of you to take this message very clearly and try to understand two things when you are doing your pre-procedural ultrasound and phenotype the pain, especially the synovial hypertrophy and also the synovial effusion, which is not very difficult as you start scanning more and more. It's a fun, it's like a video game. Like you will not leave the probe as you even on a routine day, like you can keep screening your normal volunteers, whomever you come across, because it's knee anatomy is one of the very, very good, clear, distinct superficial anatomy, which will teach you a lot. So once you start seeing the normal joints, normal effusions, I mean the minimal effusions, the normal joint, then it will be easy for you to appreciate the pathological effusions and the hypertrophy. So I urge all the participants and the fellows and the postgraduate students, start scanning because it's going to teach you a lot. Try to understand the normal knee anatomy, then automatically the abnormal, the pathology, you will come across the effusions and the hypertrophy. That is definitely going to prognosticate the procedure, and that is going to be the deterrent for your success of your genicular nerve ablation. And that should not be just blindly offered based on your KL grading is the key message here I want to submit towards the end of this journal club. And I thank once again Gautam Dasar for giving such a wonderful chance for me to participate in this. It's always great and my pleasure, and I'm very overwhelmed to be a part of such a great academic forum here. Looking forward to participate in many of the academic programs conducted by Daradia. And I congratulate the speaker Anirudh, who was really made a clear-cut presentation. I think his presentation was more into the scientific part, the criterias and all those things. I think like as the research is going to be the part of the clinical work. Again, this is an emphasis I have to make. I'm sure Gautam Das sir also will agree. We all have to start presenting, publishing more and more papers. It's the way forward, and we need to understand the language of your the research. And that bit, I think Aniruddha has done really very well. He did this job perfectly about the statistics and everything, inclusion, exclusion criteria overall. So overall, I'm very happy about the way the journal club has, and with a lot of questions in the chat box, which we could discuss in detail. And thank once again for all of you, and looking forward to meet you in the next journal club, and have a wonderful night.
Thank you, Dr. Aniruddha, and thank you, everybody. And just before ending, I'll be just asking that ICRA pin, the discounted registration is there. I'm just sharing this this slide. So this discounted registration is there only for till tomorrow, the 28th. And you just I'll be expecting all of you. Dr. Anand is also there. Is one of the very important distinguished faculty there, and we all will be meeting there. And I'll be asking you to register. Discounted registration is available till tomorrow. So thank you, Dr. Anand, and thank you everybody. Thank you everybody, and good night.
Thank you, sir.
Hello, sir.
Yes, yes.
Sir, small growth factor. How many times we will give, sir, in osteoarthritis? Anand, sir.
Which one?
Anand, can you answer this question?
Yeah, which one?
Sir,
how many times?
He is asking how many times growth factors to be given.
Growth factors can be given every 6 weeks to 8 weeks. I had given 3 to 5 times. I think 3 times is a minimal thing. I think we should.
So are you using it routinely, repeating the several times, or you are?
No, if there is if there is good more than 50% pain relief, I wait, sir. I will not give. In case
yes, we also do the same thing. If the first injection gives very good result, we do not go for the repetition of the procedure. But if the response is partial, response is your not that much, then we can think of repeating it. This is what we practice here as well.
Yeah, but sometimes patients pain relief will be less than 50%. So in my first counseling itself, I will tell them 3 to 5 injections. So and they are mentally prepared. But if they come and say their pain is relieved more than 50%, I will not offer them subsequent injections, or else I will give minimum of 3 at 6 to 8 weeks gap.
Okay.
Sir, sir, hyaluronic acid you are giving first starting. Then after that you are growth factor.
Hyaluronic acid sometimes I add, but I am not using hyaluronic acid as the only sole agent of late. I will either add with your GFC, or sometimes I will not give a HA. So I rely more on the GFC and GNE.
Okay, thank you, sir.
Thank you. Okay, thank you everybody, and good night.
Good night.
Good night, sir. Thank you so much.
Good night.
Thank you. Good night.
Thank you, sir. Thank you, everyone.
Good night.